Hey class, in this video we're going to be talking about anemia. Here are the learning objectives for the video. You can read them if you want to. So anemia is when you don't have enough red blood cells to carry oxygen to your tissues, resulting in hypoxia. And we define anemia based on hemoglobin levels. You can also use hematocrit, but the hemoglobin less than 13.5 is anemia in males, and a hemoglobin less than 12.5 is anemia in females. And those reference ranges might change a little bit depending on what lab you're using, but those are pretty good numbers to know. There are three major buckets for causes of anemia: blood loss, decreased production of red cells, and increased destruction of red cells. Acute blood loss can be caused by a lot of different things. Traumatic injuries, GI bleeding is a common cause. And it can be bad enough that it causes hypovolemic shock, which is defined as not having enough blood volume to maintain your cardiac output and oxygen delivery to the tissues. When you have acute bleeding, you may not see a change in the hemoglobin and hematocrit immediately. That's because it takes time for equilibration, where water moves from the interstitial fluid compartment into the plasma compartment. When you have acute blood loss, you are going to have a reduction in tissue oxygenation that will trigger erythropoietin secretion by the kidneys. That's going to stimulate erythroid progenitors in the bone marrow to proliferate. And after about 5 days, you're going to see these appear as reticulocytes in the peripheral blood. So signs of acute blood loss might be hypotension, tachycardia. You might see large ecchymoses. You might see overt bleeding. And symptoms may be hematemesis, where you're throwing up blood; melena, where you're passing black, tarry stools; rectal bleeding and hematochezia; hematuria, vaginal bleeding, and hemoptysis. Now, chronic blood loss also leads to anemia, and this occurs when the rate of blood loss exceeds the ability of the bone marrow to replace the blood cells that you're losing. And the most common place you're going to have chronic blood loss is going to be from the GI tract and the GU tract, also menses or abnormal uterine bleeding. And if you do suspect chronic blood loss, you do need to rule out colorectal cancer. Now, if you have someone with anemia but they don't have any history of overt bleeding and no signs of blood loss, then it's probably going to be either hemolysis or underproduction of red blood cells. And how can you tell the difference between those two things? Well, one clue is the reticulocyte count. So these are those early red cell progenitors, and normally they make up a small amount of circulating red blood cells. And if you have underproduction anemias, you're going to have very low reticulocyte counts. Whereas if you have acute blood loss or increased destruction, the bone marrow is going to crank out a lot of reticulocytes. And so the reticulocyte count should be over 3% in the setting of anemia. Now, you can use the reticulocyte percentage as a pretty good estimate for whether there's increased production in the bone marrow due to acute blood loss or hemolysis. But the severity of the anemia will actually affect the maturation time of those reticulocytes. And so we actually use something called the reticulocyte production index to correct for that. And so normally the first 3 days of reticulocyte maturation happen in the bone marrow, and it's the last 24 hours in the peripheral blood. When the bone marrow is stimulated, reticulocytes are released prematurely, leading to longer maturation times in the periphery, and larger numbers of reticulocytes are present at any given time. And so we'll correct for the severity of the anemia based on the hematocrit with a correction factor for the maturation time. And so if you have a hematocrit of 20%, that's going to give you a correction factor of 2. And say you have a reticulocyte count of 7%, that looks like you're making a lot of reticulocytes. But when you plug this into your reticulocyte production index formula, you actually end up with an index of 1.6, which is less than 2, which actually suggests that there's an inadequate bone marrow response. So don't be fooled by a high reticulocyte count. You do need to correct for the maturation time and the hematocrit to make sure that it's an adequate response. And you don't need to memorize this formula. You can pull it up on any med calculator app. So here's a nice flow chart from the book Symptom to Diagnosis, where if you have a patient with anemia, the first step is to really look to see, do they also have low white blood cell count or low platelet count, because that does affect your differential diagnosis. And if it's just isolated anemia, the next thing would be to look at the reticulocyte production index. If it's over 2, that suggests either acute blood loss or increased destruction like hemolysis. And so then the next step would be to check Coombs test, look for schistocytes on a smear, and consider other things. If it is less than 2, then you're dealing with probably an underproduction problem, and that's when you can look at your MCV, and that will help guide you in the workup from there. So here's a list of your hemolytic anemias, which we usually divide up into immune-mediated and non-immune. There's other ways to classify and organize and describe hemolytic anemias, but this is probably the most practical way as far as diagnosis and treatment. So you want to know, is this an immune process? Because that's going to change your treatment pathway. Your non-immune include your inherited disorders like your G6PD deficiency, your hemoglobinopathies, and membrane defects. You also want to look out for your microangiopathic hemolytic anemias like TTP and HUS. Think about macroangiopathic hemolytic anemias caused by trauma like prosthetic valves, infections, toxins, and then very rarely is paroxysmal nocturnal hemoglobinuria. So if you think your patient might have hemolysis, you want to check a bilirubin. That's usually going to be elevated, especially if the patient has extravascular hemolysis. This happens because the liver can't conjugate the bilirubin fast enough, so there's going to be an excess of unconjugated bilirubin in the serum. Your haptoglobin is also a helpful test here. It's usually going to be very low or even undetectable if someone has hemolysis. That's especially true if they have intravascular hemolysis. So if you have a red cell rupture within the blood vessel, you have all this free hemoglobin, which is toxic, and it's going to bind to haptoglobin and be carried to the liver where it can then be processed. Once you've consumed all your haptoglobin, you do have excess free hemoglobin floating around. That will actually be filtered into the urine, and that can injure your proximal tubular cells and can cause kidney injury. Another lab you want to test is your lactate dehydrogenase, which is going to be elevated anytime you have cellular injury. So it's not specific to hemolysis, but it does support the diagnosis in combination with the bilirubin and the haptoglobin. Now, if you suspect hemolysis and you have evidence of that based on those other labs, the next thing would be to test the direct antiglobulin test or Coombs test, because you want to know if it's an immune-mediated process or not. So you take a blood sample from your patient, and if they have an immune hemolytic anemia, all their red cells are going to be coated with antibodies. So then you wash their cells, and then you add a reagent, which is antibodies against human antibodies. Those antibodies are going to stick to those antibodies that are already coating the red cells, and then they're going to stick to each other, and you're going to get agglutination. So a positive Coombs test means that there are antibodies present on red cells. Now, if you do a peripheral smear on someone with hemolytic anemia, you might see spherocytes. This is not specific for hereditary spherocytosis. You're also going to see spherocytes in patients with other hemolytic anemias, especially your immune-mediated hemolytic anemias, because as you know, if a red cell is covered in antibodies and it goes through the spleen is going to take little bites out of that red cell, and you're going to lose surface area and form these spherocytes. And so if you see spherocytes, that is suggestive of some kind of hemolysis. The other thing you're going to be looking for on peripheral smears in somebody with suspected hemolysis is schistocytes, which are fragments of red blood cells because they've been destroyed. And that could be from a microangiopathic hemolytic anemia, or could also be from mechanical trauma. So if you see schistocytes on your peripheral smear, you should consider microangiopathic hemolytic anemias. The common ones are TTP, HUS, and DIC. You can also see it with malignant hypertension and HELP syndrome. Important to remember with TTP that your coag studies are going to be normal. So check your PT, PTT, and fibrinogen levels. That can help you distinguish TTP from DIC. In DIC, you're going to have widespread activation of the clotting cascades. You're going to consume clotting factors, and so your PT and PTT will be prolonged, and your fibrinogen will be low. And then with HUS, usually that patient is going to have a story of bloody diarrhea. This is usually caused by Shiga toxin from E. coli. And so maybe they were out of the country, maybe they ate at a Jack in the Box, and now they've got bloody diarrhea, which leads to kidney failure, thrombocytopenia, and this hemolytic anemia. So treatment of hemolytic anemia depends on the type. If it's autoimmune, usually you're going to start with steroids like prednisone, pretty high doses to try to suppress it. If that's not effective, you can add on rituximab, which gives you a much longer duration of effect. And if it's refractory to that, then sometimes these patients have to have their spleen removed. If the patient has TTP, then the treatment is plasmapheresis, steroids, also rituximab, because you need to treat the antibodies that are causing that. And then hereditary spherocytosis can be treated with splenectomy. Paroxysmal nocturnal hemoglobinuria is a complement disorder, and so you can use eculizumab, which targets C5. All right, so if you look at your reticulocyte production index and it's less than 2%, then you know you have an underproduction problem. The bone marrow just can't make red cells for whatever reason. And usually it's because of a nutrient deficiency, but there are other causes. And this is where it's helpful to break them down by their MCV. So if you see an MCV less than 80, we call that microcytic anemia. And there's very specific things, iron deficiency being the number one. But also think about thalassemias, sideroblastic anemias, copper deficiency, and zinc poisoning. Normocytic anemias are going to have an MCV between 80 and 100. The most common cause of a normocytic anemia is anemia of inflammation, but early iron deficiency can also be normocytic. And then you have to think about a lot of other bone marrow disorders if you've ruled out anemia of inflammation. If your MCV is over 100, we call that macrocytic anemia, and your megaloblastic anemias are going to have a really big MCV. Those are usually going to be due to vitamin B12 and folate deficiency. And then you can also see macrocytic anemia from alcohol use, liver disease, hypothyroidism, and myelodysplastic syndrome. So let's talk about the most common cause of microcytic anemia. That's iron deficiency. This is the most common nutritional deficiency in the world. It's also the most common cause of anemia worldwide. So normally your diet has about 10 to 20 milligrams of iron a day, which mostly comes from heme, and heme iron comes from meat. 20% of heme iron is absorbable. You can get iron from plants though, so if you're a vegetarian, that's okay. You can still get iron, but it is less absorbable. But you don't actually need that much every day, only about a milligram of dietary iron, because most of your daily iron requirements are going to come from just recycling the hemoglobin that you already have in your body. Iron is absorbed in the proximal duodenum through these DMT1 transporters, and you'll see that it usually comes in as ferrous iron, which is the Fe2+. That then gets oxidized by hephaestin and ceruloplasmin to ferric iron, the Fe3+, which can then bind to plasma transferrin. And it gets from the enterocyte into the bloodstream through the ferroportin transporter, and that is regulated by hepcidin. So if hepcidin is elevated, it will shut off ferroportin activity, and the iron will be trapped in that enterocyte, and then it could just be shed in the gut. Whereas if the body needs iron, the hepcidin should be low, and the iron can come in through that ferroportin. Now, iron is transported by a protein called transferrin, which is synthesized by the liver. And I like to think of transferrin as basically just like this bus that picks up iron and then takes it where it needs to go. So it's going to deliver it to the different cells, including in the bone marrow, so they can make hemoglobin. And the amount of transferrin you have determines your total iron binding capacity. And then we can calculate what your transferrin saturation is based on how much iron you have and how much of your transferrin is saturated with iron. So how full is your bus is basically your transferrin saturation. And normally it's going to be about 33%. And you will see it higher in iron overload states. So if someone has hemochromatosis or they have a thalassemia and they've been getting lots of blood transfusions, their transferrin saturation is going to get very high. If you have iron deficiency, your transferrin saturation will be very low because there's just not enough iron to ride the bus. And so your saturation will be less than 20% usually. Now, free iron is very reactive and leads to free radicals, so it needs to be stored in this protein iron complex called ferritin. Ferritin is found in parenchymal cells of the liver. It's also found in macrophages of the spleen and the bone marrow. And your ferritin levels correlate very well with your total body stores. So, serum ferritin is your best overall test for measuring if someone has enough iron. And if they have a ferritin less than 30, that's very suggestive of iron deficiency. Or it's really just the definition of iron deficiency. Now, iron absorption is regulated by hepcidin, like we mentioned before. This is a protein that's synthesized by the liver in response to increased intrahepatic iron levels. Hepcidin will bind to ferroportin on the enterocyte, causing it to be endocytosed and degraded, and then that enterocyte will just be sloughed off with the iron inside. We also have ferroportin on macrophages. And so if you have too much hepcidin, it's also going to prevent you from releasing iron from those macrophages. Hepcidin is suppressed by another protein called erythroferrone, and erythropoietin stimulates erythroferrone production. Often the first sign of iron deficiency is the anemia, but iron deficiency causes other problems too, including impaired mitochondrial function, cellular metabolism, and neurotransmitter synthesis. So symptoms of iron deficiency may be present even before someone has anemia, including fatigue. So the major causes of iron deficiency anemia are going to be inadequate intake, impaired absorption, and chronic blood loss. And so inadequate intake can be like a baby who's just drinking too much milk, which is low in iron and also impairs iron absorption, or poor diet in someone who's like elderly or impoverished. Impaired absorption, you'll see that with celiac disease, which affects the small intestine and the duodenum where iron is normally absorbed. Also, patients with gastrectomies will have impaired absorption because they have less acidity to maintain ferrous iron, which is more bioavailable than ferric iron. And so they're going to have less of that absorbed in the proximal duodenum. But really, the number one thing you should think about when you have a patient with iron deficiency anemia is chronic blood loss. And that could be from an occult GI cancer in the colon or other GI bleeding. It could be from heavy menstrual bleeding or other dysfunctional uterine bleeding. It could be from hematuria. And so really that's what you need to zero in on if you diagnose someone with iron deficiency anemia, is try to figure out if they have any chronic blood loss. Iron deficiency anemia can cause a lot of different symptoms. It can cause fatigue, weakness, reduced exercise tolerance, and that may be present before they even have anemia. You may see pale skin or conjunctival pallor, cheilitis, koilonychia, and restless leg syndrome is a very common presentation of iron deficiency. So if you have a patient with RLS, you should definitely check their iron levels. Pica is another classic symptom of iron deficiency. People craving non-foodstuffs like clay or dirt. Plummer-Vinson syndrome is a rare triad of esophageal webs, atrophic glossitis, and microcytic anemia due to iron deficiency. In iron deficiency, the serum iron is going to be low. Your ferritin is going to be less than 30. Transferrin saturation will be less than 20%. Your total iron binding capacity is going to be elevated because the liver is going to crank out more transferrin to try to go scavenge more iron. So you're going to have a really high transferrin level and a high total iron binding capacity, but a low saturation. If you look at a smear, the red cells are hypochromic and microcytic. Your MCV will be less than 80. You will see red cells with that enlarged zone of central pallor, and you may see pencil cells as well. So here's a peripheral smear of someone with iron deficiency. You can see that they have the enlarged zone of central pallor and the cells are smaller than normal. So hypochromic and microcytic anemia. So the treatment of iron deficiency anemia is pretty straightforward. You just need to replace their iron. You can do that with oral iron, which you should probably do every other day. If you give it too frequently, it will stimulate hepcidin, which will shut down any more absorption. Some people think vitamin C may improve your oral iron absorption. Proton pump inhibitors, milk, and tea will reduce your oral iron absorption, so you don't want to take them around the same time. It takes a very long time to replace someone's iron with oral iron, and it does cause a lot of side effects like nausea, diarrhea, and constipation. So, if you really want to replace somebody's iron and you want to do it quickly with minimal side effects, the best way to do that is with intravenous iron, which you can usually replenish their entire body store with 1 to 3 doses. And then, if someone's really anemic, their hemoglobin's less than 7 from iron deficiency, go ahead and give them a blood transfusion. All right, next we'll talk about some normocytic anemias. These are anemias with an MCV between 80 and 100. You'll see that number one is anemia of inflammation. That's the most common. Early iron deficiency can be normocytic. And then you have less common things like bone marrow infiltration, aplastic anemia, pure red cell aplasia, and hematopoietic neoplasms. So anemia of inflammation is also called anemia of chronic disease. It's the second most common cause of anemia after iron deficiency. In the hospital, it's usually the most common cause you're going to see, especially in patients with chronic illness. So inflammation leads to iron sequestration. So this is really like a functional iron deficiency caused by inflammation. So you have cytokines like IL-6 and IL-1 that stimulate hepcidin production by the liver. As you recall, hepcidin is going to bind ferroportin and cause its degradation. And you have ferroportin on macrophages, which is where a lot of your ferritin is stored. So you're going to trap iron in the macrophages when you upregulate hepcidin. So even though these macrophages are full of iron and you have tons of iron in your body, it's unavailable for hemoglobin synthesis. And so you are functionally iron deficient. This most likely evolved to fend off infections. We don't want microbes in our bloodstream having access to all of our iron. It's an essential nutrient for them. So it probably evolved for that reason to just shut down all iron availability. But if you have a chronic inflammatory disease, that becomes a big problem. Cytokines also suppress your erythropoietin secretion, and so you're not going to make as many red blood cells. Normally, your EPO increases a hormone called erythroferrone, which downregulates hepcidin. But if your EPO is low, your erythroferrone is going to be low, and that means your hepcidin is going to be unsuppressed. So that's going to worsen your iron sequestration. And then with inflammation, your red blood cells just have a shorter lifespan. So cytokines and free radicals and complement factors are going to damage your red cells. So you're going to have more erythrophagocytosis by macrophages in the spleen, more red cell turnover. And usually this is a slow process with like chronic inflammation. But if you have a really severe acute illness like sepsis, that can cause very rapid anemia by this mechanism. There's a lot of different things that can cause anemia of inflammation. One of the classic things would be like a chronic infection like osteomyelitis or like a smoldering endocarditis, but acute infections can do it too. Autoimmune diseases like rheumatoid arthritis and IBD, cancer, CKD, heart failure, chronic lung diseases, especially COPD, chronic liver disease, and obesity are all causes of anemia of inflammation. So with anemia of inflammation, you're going to have a low serum iron. Your transferrin saturation can be normal or it could be low. And when it's low, you should think about coexistent iron deficiency. The ferritin is going to be normal or high, usually over 100. And your TIBC is going to be low because transferrin synthesis is actually suppressed by cytokines. So liver isn't going to make a lot of transferrin when there's inflammation. So that is one clue that can help you differentiate between iron deficiency and anemia of inflammation is the TIBC. If it's low, it's likely due to inflammation. Your red cells are usually going to be normocytic and normochromic, so the smear isn't very helpful. So you can have patients that have both anemia of inflammation and iron deficiency. It's fairly common, especially in the hospital. And it can be challenging to figure out because the labs don't always add up. So your ferritin will be normal or elevated sometimes because of that inflammation. Ferritin is an acute phase reactant, so you're going to have more ferritin when you're inflamed. The transferrin saturation should still be low, usually less than 20%. And so if you have a high transferrin saturation, it makes iron deficiency less likely. If your transferrin saturation is kind of borderline or indeterminate, you can order another lab called the soluble transferrin receptor. And if that's elevated, it confirms that the patient has iron deficiency. So here's just a table kind of summarizing the iron studies for both iron deficiency and anemia of inflammation. In iron deficiency, you're going to have a low ferritin, low serum iron, high total iron binding capacity, low transferrin saturation, and a high soluble transferrin receptor. For anemia of inflammation, your ferritin is going to be normal or high. Your serum iron will be low. Your TIBC or transferrin will be low, and your transferrin saturation usually normal but can be low. And then if they don't have iron deficiency as well, the soluble transferrin receptor will be low. Treatment for anemia of inflammation can be quite challenging because a lot of these inflammatory conditions just don't have great treatments. You think about congestive heart failure and COPD and obesity. They're just difficult things to treat. But if they have an infection or an autoimmune disease like rheumatoid arthritis or inflammatory bowel disease, you want to get those under control. If they do have iron deficiency, you want to replenish that so that they have the substrate they need to make new hemoglobin. And then a lot of patients may benefit from an erythropoiesis stimulating agent or ESA like epoetin or darbepoetin. These are especially useful in patients with chronic kidney disease because they're not making erythropoietin. All right, last we have our macrocytic anemias where the MCV is over 100. We have our megaloblastic anemias like vitamin B12 and folate deficiency, which can also be caused by different medications. And then our non-megaloblastic anemias like chronic alcohol use, liver disease, specifically spur cell anemia, hypothyroidism, and myelodysplastic syndrome. Now, vitamin B12 and folic acid are important cofactors required for the synthesis of thymidine. So if you have deficiency in these vitamins, you're going to have impaired DNA synthesis, inefficient hematopoiesis, and you end up with these large erythroid precursors in red cells, and that's why we call it megaloblastic anemia. All right, this next slide is a little bit confusing, and honestly, it's mostly step one trivia, but it is important to know why vitamin B12 and folic acid deficiency cause anemia, and it's because they're both required in the synthesis of thymidine. So methylcobalamin is a cofactor for the conversion of homocysteine to methionine. So methylcobalamin is going to donate a methyl group to that reaction. And then it's going to be just regular cobalamin without the methyl group. So in order to be regenerated, it needs to get a methyl group from somewhere else, and it's going to get it from N5-methyl tetrahydrofolate. And so that then generates regular tetrahydrofolate and a new methylcobalamin. So if you don't have cobalamin or vitamin B12, then that N5-methyl tetrahydrofolate doesn't have anything to donate that methyl group to, so it can't become tetrahydrofolate, which is required for that synthesis of thymidine. And so this basically creates a functional lack of folate when you have vitamin B12 deficiency, and that's going to lead to an increase in homocysteine levels and also an inability to make thymidine. In both vitamin B12 and folic acid deficiency, your cells are going to be large. MCV will be over 100. They can be different sizes, different shapes. The classic thing you're going to see on a smear are the hypersegmented neutrophils, where they're going to have 5 or more nuclear lobules. Your bone marrow is going to be hypercellular because in response to the anemia, you're going to crank out more EPO. They can have cellular apoptosis that leads to pancytopenia. And in some cases, severe vitamin deficiency, you can actually have intramedullary hemolysis, and that could present with elevated lactate dehydrogenase and a decrease in haptoglobin. So this is your classic smear where you see these neutrophils that are hypersegmented and then big red cells. Folic acid deficiency is usually going to be due to inadequate intake. So your classic board question will be a patient with alcohol use disorder who's not eating anything. Can also be from impaired absorption, hemodialysis, pregnancy, chronic hemolysis, and medications like methotrexate and trimethoprim, which inhibit dihydrofolate reductase, which is the enzyme that converts dihydrofolate to tetrahydrofolate. Folic acid deficiency is pretty easy to treat. You just give them oral folic acid supplementation. It is important to remember, though, that when you replace folic acid, that can correct the hematologic abnormalities that you see in B12 deficiency, but it won't fix their neurologic problems. So you always want to check B12 levels in patients with folate deficiency, especially if you're going to treat them with folic acid replacement. Now, vitamin B12 is also a cofactor for the conversion of methylmalonyl-CoA to succinyl-CoA. And so if you have vitamin B12 deficiency, you're going to have accumulation of methylmalonic acid in the plasma. And so that is a very specific lab for vitamin B12 deficiency, whereas homocysteine will be elevated in both vitamin B12 and folate deficiency. So vitamin B12 deficiency, in addition to megaloblastic anemia, can cause severe neurologic problems, so-called subacute combined degeneration of the spinal cord. So you're going to have demyelination of the dorsal column, which leads to reduced proprioception and vibration sensation and progresses to ataxia. You have demyelination of the lateral corticospinal tracts, which leads to spastic paresis, clonus, paraplegia, incontinence, and it can also cause cognitive impairment, dementia, and psychiatric symptoms. So very important to test for B12 deficiency in folks with unexplained neurologic symptoms. B12 is absorbed in the terminal ileum, and it requires intrinsic factor to be absorbed. Intrinsic factor is made by the parietal cells of the stomach. You can absorb B12 passively in the terminal ileum, but it's very inefficient. So it's more efficient if it's bound to intrinsic factor. B12 deficiency can be caused by inadequate intake, but the liver can store a lot of it, so it usually takes years to develop after you stop consuming things that have B12 in them, like milk, meat, fish, eggs, any animal products. So if you are a vegan and you're not eating any of those things, then you should take a supplement. Otherwise, you could develop B12 deficiency, but it usually takes many years. Atrophic gastritis is a really important cause of B12 deficiency. It can be autoimmune, which is called pernicious anemia. It can be from chronic H. pylori infection, which causes that gastritis and achlorrhea, and it can also be from long-term PPI use. Patients with gastrectomy no longer have parietal cells to make intrinsic factor, so they don't absorb B12 as well. And then because B12 is absorbed in the terminal ileum, any diseases that affect the ileum, like Crohn's or having an ileal resection or small bowel overgrowth or parasite infection, can cause B12 deficiency. Pernicious anemia is a commonly tested cause of B12 deficiency. This is an autoimmune disease that attacks the parietal cells, or it can actually have autoantibodies against intrinsic factor as well. Measuring those antibodies isn't necessarily very helpful in diagnosing this because they can be present in patients without this. It is associated with chronic atrophic gastritis and increases your risk of gastric cancer. The classic patient with pernicious anemia is also going to have other autoimmune diseases like vitiligo or Hashimoto's thyroiditis. Vitamin B12 deficiency can be treated with supplementation. Usually you can do oral supplements, especially if it's just from inadequate intake. Patients who you're worried about absorption, you might need to do intramuscular injections for them. So if they have severe malabsorption or pernicious anemia, you can do that. But usually you can still treat those patients with high-dose oral treatment because there is that passive absorption in the ileum. Okay, we made it to the end of the video. Here's a summary of some of the key points we talked about. You can use the reticulocyte production index to help distinguish between hemolysis or underproduction If you do suspect hemolysis, you can check LDH, haptoglobin, and bilirubin, and if those are positive, you should send a Coombs test and get a peripheral smear to look for schistocytes. If you suspect anemia of underproduction, the MCV is very helpful to guide your workup, and iron deficiency and inflammation are the most common causes of anemia that you're going to see. Thanks for your attention.